Welcome to this high-yield clinical explainer. We are bypassing the usual introductions today because we need to immediately tackle some incredibly complex systemic pathologies. If you're targeting that 270 plus board score, this is exactly what you need. We're going to strictly detail the intricate mechanisms, the discrete management steps, and the precise markers required for elite clinical reasoning. So let's get right into it.
Module 1, Systemic Sclerosis and Pulmonary Kinetics.
Let's start by looking at the fibrotic deposition mechanism that is so characteristic of systemic sclerosis. This is driven by an intense inflammatory response where excessive deposition of types I and III collagen progressively remodels the patient's tissue. Clinically, you'll see this begin with puffy fingers, but it inexorably evolves into sclerodactyly, which severely restricts joint mobility. You can also see severe microstomia here, characterized by a notable loss of facial wrinkles and a very tight, purse string appearance around the lips. Now, serologically, we have to stratify this disease into two major subsets, and you need to have these memorized cold. Diffuse cutaneous systemic sclerosis involves proximal skin thickening and correlates strictly with anti-topoisomerase 1, also known as anti-SCL70 antibodies. On the other hand, limited cutaneous systemic sclerosis is restricted to distal skin thickening and is hallmarked by anti-centromere antibodies. Okay, so here is the absolutely crucial point, understanding the pulmonary stratification between these two subsets. Both are going to present with dyspnea and a low diffusion capacity for carbon monoxide, or DLCO. But look at the divergence here. Diffuse systemic sclerosis overwhelmingly drives interstitial lung disease. That presents with restrictive spirometry, meaning a low forced vital capacity, and bilateral opacities on imaging. In sharp contrast, limited systemic sclerosis bypasses the lung parenchyma entirely. It directly remodels the pulmonary vasculature, causing isolated pulmonary arterial hypertension. So you're going to see completely normal spirometry, clear lungs on an X-ray, and signs of right ventricular hypertrophy. Let's move straight into our first integrated assessment. This requires you to synthesize physical exam findings with specific pulmonary kinetic data. You have a patient presenting with Raynaud's, esophageal dysmotility, and a right ventricular heave. Pulmonary function testing reveals a completely normal forced vital capacity, but a severely reduced DLCO of 40%. So what is the most appropriate next step in management? The correct answer here is an echocardiogram. Let's detail exactly why. The combination of a normal FVC, a severely reduced DLCO, and a right ventricular heave completely isolates pulmonary arterial hypertension over interstitial lung disease. This definitively eliminates option 1, a high-resolution CT scan, which is the diagnostic modality of choice if we were looking for ILD. Now, option 3, right heart catheterization, is the eventual gold standard for PAH confirmation, but the echocardiogram is the mandatory first non-invasive diagnostic step. Option 4, pulmonary angiography, is reserved for chronic thromboembolic disease, not primary vascular remodeling. And finally, option 5, spirometry with bronchodilator response, assesses for obstructive diseases like asthma, which is entirely inconsistent with a normal FVC and right heart strain. Module 2, granulomatosis with polyangiitis and otolaryngologic destruction. Moving on to the small vessel vasculitis, we're going to map out the aggressive systemic reach of this disease. Granulomatosis with polyangiitis, or GPA, is defined by a highly specific necrotizing triad. First, you have severe upper respiratory tract involvement. Second, lower respiratory tract cavitations, and these frequently bleed, causing hemoptysis. And third, renal involvement, manifesting as focal segmental necrotizing glomerulonephritis with crescents. Now, while a positive C-ANCA serologic marker strongly suggests the diagnosis, it is absolutely vital to remember that definitive confirmation strictly mandates a tissue biopsy demonstrating necrotizing granulomatous inflammation. Let's focus in on that relentless upper airway target. Unlike many other vasculitis, GPA heavily and aggressively targets the upper airway mucosa and cartilage. This destructive process drives chronic purulent rhinosinusitis, recurrent otitis media, and ultimately an irreversible architectural collapse. This results in the pathonominomic saddle nose deformity. This brings us to a critical distinction you have to be able to make on the wards and on exams. Both granulomatosis with polyangiitis and Goodpasture disease can present with pulmonary hemorrhage, causing hemoptysis, and rapidly progressive glomerulonephritis, causing acute renal failure. However, Goodpasture disease, which is driven by antiglomerular basement membrane antibodies, strictly isolates its attack to the lungs and kidneys. GPA, on the other hand, features the profound addition of that upper airway and otolaryngologic destruction we just talked about. Let's evaluate this classic presentation to correctly identify the underlying immunologic mechanism. A patient presents with epistaxis, a collapsed nasal dorsum, hemoptysis, and an elevated creatinine. Which autoantibody target is most likely mediating this syndrome? The correct target is antiproteinase 3. The presence of that collapsed nasal dorsum definitively isolates granulomatosis with polyangiitis, which is mediated by CANCA, also known as antiproteinase 3. Option 1, antiglomerular basement membrane, causes Goodpasture syndrome, which lacks upper airway destruction. Option 2, anti-myeloperoxidase, or PANCA, is associated with microscopic polyangiitis and eosinophilic granulomatosis, neither of which classically causes massive nasal cartilage collapse. Option 4, anti-double-stranded DNA, defines systemic lupus erythematosus. And option 5, anti-topoisomerase I, defines diffuse systemic sclerosis, as we discussed in Module 1.
Module 3, eosinophilic granulomatosis, polyangiitis, and neurovascular traps.
This disease features a mandatory clinical prelude. It is almost always preceded by adult-onset, severe, treatment-refractory asthma, accompanied by chronic rhinosinusitis and nasal polyposis. The defining hematologic signature here is profound peripheral blood eosinophilia, typically greater than 10%. These eosinophils relentlessly infiltrate tissues, resulting in palpable purpura, which are those multiple, scattered, non-blanchable red papules distributed over the lower extremities. And this drives severe cardiovascular damage and end-organ ischemia.
Now, a devastating and highly testable complication arises when this eosinophilic vasculitis critically targets the peripheral nervous system. The intense inflammation causes infarction of the vasa nervorum. Those are the tiny blood vessels that supply your peripheral nerves. This ischemia precipitates mononeuritis multiplex, which classically presents as an abrupt, acute, asymmetric peripheral neuropathy. Think of a sudden, unexplained wrist drop or foot drop.
We absolutely must distinguish EGPA from aspirin-exacerbated respiratory disease, or AERD. Both conditions prominently feature asthma and nasal polyps. However, AERD is triggered strictly by the ingestion of NSAIDs, which block the cyclooxygenase pathway. EGPA is distinguished by a positive PANCA, massive peripheral eosinophilia, palpable purpura, and systemic vasculitis causing that asymmetric neuropathy. This scenario requires you to link the atopic triad directly to the specific vascular complication. A 45-year-old with late-onset asthma presents with a new-onset left foot drop and a palpable purpuric rash. What is the precise pathophysiologic mechanism for the neurologic deficit?
The correct mechanism is option 2, disruption of the vasa nervorum. The combination of adult-onset asthma, palpable purpura, and an asymmetric focal neurologic deficit explicitly points to eosinophilic granulomatosis with polyangiitis. The foot drop is a direct result of vasculitic infarction of the vasa nervorum. Option 1, demyelination of central motor tracts, describes multiple sclerosis. Option 3, anterior horn cell degeneration, describes amyotrophic lateral sclerosis. Option 4, antibodies against the neuromuscular junction, describes myasthenia gravis. And option 5, NSAID-induced metabolic blockade, describes AERD, which, remember, does not cause vasculitic purpura or nerve infarction.
Mastering these specific distinctions, from fibrotic markers and pulmonary kinetics down to necrotizing triads and nerve infarctions, is the mandatory standard for elite clinical reasoning and exact patient management. Definitive diagnosis in rheumatologic and vasculitic syndromes requires precise correlation of end-organ damage patterns with their singular autoantibody and histopathologic signatures. That is the baseline for high-level medical practice. Thank you for joining this explainer.